join this very interesting FIP event of today. Today webinar is about the use of doxycycline for the prevention of bacterially sexually transmitted infections. And we will welcome three speakers on three different topics related to this issue of STI prevention. First of all, I would like to say that I'm Darija Benko. I work at the hospital pharmacy at the University of Szeged, and I'm also working in the clinical pharmacy department as an associate professor. Actually, my co-moderator is Darija Poje, who will introduce also herself.
So good afternoon. Thank you all for being at this important and attending this important virtual event. We have really very distinguished guests, and I would just say that sexually transmitted infections are common and preventable causes of morbidity and serious complications. Among men who have sex with men and transgender women, at increased risk for sexually transmitted infections, several randomized trials have shown that post-exposure prophylaxis with doxycycline reduces the incidence of syphilis, chlamydia, and gonorrhea. Deciding whether to use doxycycline in this situation depends on history of bacterial sexual transmitted disease in the prior 12 months or whose planned sexual activities increase the likelihood of STI exposure, like multiple or anonymous partner. Although doxycycline can reduce the risk of chlamydia, gonorrhea, and syphilis in such individuals, however, it's commonly associated with gastrointestinal side effects and the long-term effects of antimicrobial resistance, which are uncertain. And today we will discuss about this topic. And I really am proud and honored to moderate this event and to have these distinguished guests. Thank you.
Okay.
So, Ria, you can continue.
Okay, so we would like to say that this webinar, of course, is being recorded and is live streamed via the YouTube. All the recordings will be available after the event at the event.fip.org email address. We will have 3 lectures, and after the 3 lectures, you will have the chance to ask questions at the question box that you will see down on your menu. And of course, any feedback is welcome to the email address that you see on the screen. And if you would like to become a FIP member, you can register as a member at the FIP webpage. So thank you. Today, the attendees and the participants will learn about 4 basic things. First of all, you will get insight about the supporting evidence behind the use of doxycyclines against these sexually transmitted infections. We will discuss the potential benefits and the potential risks of this doxycycline prophylaxis. And of course, the impact of this treatment on the emergence of antimicrobial resistance. And finally, we will discuss and have insights in the role of pharmacists, how to provide a good approach for the prevention of these bacterial sexually transmitted infections. Okay, as you can see, the agenda for today, the title of the 3 lectures. After the welcome and introduction that we are now, we will have a lecture on we will learn about the supporting evidence behind the prophylactic use of doxycyclines. The next one will be about the resistance development related to the use of doxycycline. And the third lecture the considerations and public health implications of the prophylactic doxycycline use. We will have three distinguished lecturers that we will introduce one by one before the lectures. And after the lectures, as I told you, you can ask questions and we can have a discussion on the topics. And finally, we will close with a wrap-up. So, yeah, sorry.
Okay,
Please,
okay.
Do it.
Okay. First is Dr. Bachmann. She is the Chief Medical Officer in the Division of Sexually Transmitted Disease Prevention, National Center for HIV, Viral Hepatitis, STD, and Tuberculosis Prevention in U.S. Center for Disease Control and Prevention, or CDC in short, what we all better known. Prior to coming to CDC in 2018, Dr. Bachmann was a professor of medicine at Wake Forest University Health Sciences, Winston-Salem, NC, and medical director, Guilford County Department of Health and Human Services, Public Health Division, NC. Bordered in internal medicine and infectious diseases, Dr. Bachmann specializes in STD and HIV care with experience practicing in academic and public health setting for over 30 years. Her research has addressed a variety of STD, HIV control issues in both clinical and non-clinical settings. Dr. Bachmann has authored over 90 peer-reviewed manuscripts and book chapters. She is a team lead to development of CDC recommendations for providing quality STD clinical services, 2020 and 2021 CDC STI treatment guidelines, and she is the lead author of the CDC clinical guidelines on the use of doxycycline post-exposure prophylaxis for bacterial sexually transmitted infection prevention. Thank you for accepting this call, and the floor is yours. Thank you.
Thank you. And thank you for inviting me to speak to all of you today. I'm going to try the slide control out here. Okay. So I have a brief amount of time here to kind of give you some background on the guidelines and how, you know, the evidence base for the recommendations. So that's what I will cover in my part of the talk today. I have no disclosures or to make or conflicts of interest. And just briefly, I'll touch on the state of STIs in the United States. I'm going to summarize briefly the evidence for doxycycline PEP. We don't have enough time to go study by study. I'll go through what the recommendations currently state, and then show you some implementation, early implementation information, and then some monitoring considerations. So in the United States, STIs have been climbing for more than a decade. We did just release our 2023 surveillance report last month. And although STIs still continue at very high levels in the US, there are some potentially positive signs. So gonorrhea cases now are below pre-pandemic levels and have decreased now for 2 years straight. Also syphilis cases, though they increased, it was only an increase of 1% compared to double digits in the previous, I think, 10 years. Congenital syphilis cases also are slowing down, though they continue to increase. So 3% increase compared to 30% increase in previous years. So we know STIs, though, continue to be a significant issue. And so, you know, it's important that we have new interventions to address these. And so today what we're talking about specifically is the use of doxycycline as post-exposure prophylaxis to prevent bacterial sexually transmitted infections. There have been 3 different studies that these are summary data here on this slide. 3 randomized clinical trials, all in men who have sex with men and transgender women, and all in individuals who are using HIV PrEP or are living with HIV. And the study designs are relatively similar. They all used doxycycline 200 milligrams taken within 24 hours optimally after sex, but no later than 72 hours. as a way to decrease bacterial STIs. And what they found is that for chlamydia, there were reductions of 70 to 89% in the doxycycline PEP arms. For syphilis, also similar declines, as you can see here, 73 to 87%. Unsurprisingly, the results in gonorrhea were a bit mixed. So the first French study that looked at this did not find significant reductions in gonorrhea, though the DoxyPEP study that was conducted in the United States and the second French study, DoxyVac, did see around 50% reductions in gonorrhea. So substantial effects. The number needed to treat decrease the probability of an incident STI per quarter was around 1 in 4, or 1 out of 4, 1 out of 5. So that's a low number needed to treat. Another study that was conducted is a DPEP study, and this study was conducted in cisgender women who were receiving HIV PrEP in Kenya. And as you can see here on this graph to the left, there were not significant changes in STI incidence between the DoxyPEP group and the standard of care group. The reasons for this are still being worked out. It's thought that some of this may be due to a lack of adherence. There was a high adherence reported during the study, but when quarterly hair samples were evaluated, only about 29% of the hair samples had measurable doxycycline in them. But there could be potentially other reasons as well, and that is something that needs to be worked out. So because of the strong data in men who have sex with men and transgender women, it was felt that some guidance needed to be put forward around the use of this new intervention. And the CDC, following our involved process that is to do guidelines, we did get our guidelines out in June of 2024 for providers and the use of this new intervention. And so briefly, what did the guidelines say? The guidelines specify that providers should counsel gay, bisexual, and other men who have sex with men and transgender women who've had at least one bacterial STI in the last year, and that's specifically gonorrhea, chlamydia, or syphilis, that this group should be counseled about the benefits and harms of DoxyPEP and should be prescribed DoxyPEP through shared decision-making. So understanding the pros and cons, the provider should prescribe if the patient going through all that decides they want to take this. And because of the randomized the randomized clinical trial data was strong, the quality of evidence strength of recommendation was in A1. Now, we also state in the guidance that any formulation of doxycycline is acceptable. In terms of how much doxycycline should be prescribed, it really should be based on the individual and how much they need between visits, and we're recommending follow-up in 3 to 6 months. And also that providers should assess ongoing need for DoxyPEP every 3 to 6 months, just because people's, their situations may change. Now, when it comes to some of the other ancillary services that are recommended for when DoxyPEP is used, it's really important that bacterial STI screening is taking place. Men who have sex with men and transgender women should undergo bacterial STI testing and anatomic sites of exposure at baseline and every 3 to 6 months thereafter. For individuals who are HIV negative and receiving HIV PrEP, they should receive HIV screening as per current recommendations. And if they're HIV negative and not on HIV PrEP, then it should be considered to screen them for HIV every 3 to 6 months. It is really important that DoxyPEP, when offered, should be implemented in the context of a comprehensive sexual health approach. So by no means will this antibiotic solve our STI epidemic alone. There needs to be other ongoing activities. This is just part of a toolkit. discussions about other ways to reduce risk, ensuring people are tested or screened and treated as appropriate for STIs, vaccinations that are indicated should be given. And of course, if someone does not have HIV, they should be referred and linked into HIV PrEP. And then, of course, linked into other services as appropriate. So this is part of a comprehensive approach. We could not make recommendations at this time for cisgender women, cisgender heterosexual men, transgender men, or other queer and non-binary individuals due to insufficient evidence that so that we could not assess the balance of benefits and harms in these populations. Some of the counseling that should occur include discussion of potential benefits as well as known and unknown harms of DoxyPEP, and that includes the known side effects like phototoxicity, esophagitis, gastrointestinal intolerance, and methods to mitigate these side effects. It also should be discussed with the patient the potential for the development of antimicrobial resistance and other pathogens and commensals, and the unknown risks on the microbiome. It should be emphasized to patients the need to take doxycycline exactly as prescribed and only for its intended purpose. And of course, potential drug interactions should be evaluated. Now, before I wrap up, I wanted to just show some early data out of some of our partners presented earlier in San Francisco, specifically the San Francisco Department of Health. And in San Francisco, they actually adopted DoxyPEP before the CDC guidelines were released. So they started using DoxyPEP in 2022 in several of their clinics. And as you can see here, based on their case-based surveillance, they modeled what the predicted trend of chlamydia and syphilis, and I'll show you gonorrhea in a minute, predicted trend of those STI cases would be if no intervention took place. And you can see that on the blue line here. The purple line is the pre-period trend, then the blue line is what would be predicted. The red line is actually what happened. And there were approximately 50% reductions in both chlamydia and in syphilis amongst men who have sex with men in San Francisco as of the time this was measured in November of 2023. So approximately a year after release of their guidelines. And not entirely surprisingly, they did not see reductions in gonorrhea. As you can see here, there was actually a little bit of an increase in gonorrhea during the same time frame. And when they looked at rates or chlamydia cases, specifically in cis women, those cases increased by almost 3% during that same time period where the MSM population experienced reductions. So this was felt to be very promising. Now, understandably, and the subject of this other talks today is, there are concerns about the development of resistance. And so these are data presented from the DoxyPEP group, and that's the US-based study that took place in San Francisco and Seattle. And they looked at Staph aureus at baseline and at 6 months follow-up. And what they found when the standard of care arm was compared to the DoxyPEP arm, here on the left side of the slide, that there was a 14% absolute reduction in colonization or carriage of Staph aureus in the DoxyPEP group at 6 months and 12 months. But if you, amongst those Staph aureus isolates that they did find, the DoxyPEP group had an 8% absolute increase in resistance to tetracycline. So less colonization, but of the staph that were isolated, more likely to be doxy resistant in the DoxyPEP arm. This group also looked at the expression of tetracycline antimicrobial resistance genes, and they did find that there was increased tetracycline antimicrobial resistance gene expression in the DoxyPEP arm at month 6, as you can see in green. And then also that there was a bit of a dose association with the number of doses of doxycycline and the increase in antimicrobial tetracycline antimicrobial resistance genes here on the right on that graph. They also looked at diversity and abundance in the gut and found that over 6 months that the alpha and beta diversity, bacterial diversity did not differ between the standard of care and doxy arms. And the total bacterial abundance did not seem to be different over that time frame. And this is something that will continue to be evaluated. So to sum up, just to, to acknowledge that there are legitimate concerns about AMR. At CDC, we definitely have our eye on this, and we're going to leverage our gonococcal isolate surveillance programs. We have several of those in place now to continue to monitor for resistance. We also have systems in place for non-STI pathogens like Staph aureus, Strep pneumo, and others. And also, we have plans to monitor just doxycycline use across the country as this intervention rolls out. So those are some of the things that we've put into place. There are other measures that are being taken with funding other studies, our partners like NIH and our local partners who will be evaluating this as well. So I'm going to finish with that and turn it over to my other colleagues for their remarks. Thank you.
Thank you very much, Laura, for this excellent lecture. I would like to introduce our next speaker, Thibaut Van Bielen. Thibaut Van Bielen is a practicing medical doctor and postdoctoral researcher from Belgium, Antwerp, University of Antwerp. He has two main research topics. The first one is the prevention of HIV, and the second one is the prevention of AMR in bacterial sexually transmitted infection. Okay. The title of his lecture is the risk of emerging tetracycline resistance associated with the use of doxycycline in sexually transmitted infection prevention. So the floor is yours. Please, if you would like to add something to your short bio, you can of course do it if I miss something important detail. Thank you very much, and the floor is yours.
Thank you, Ria. I hope you can all hear me. I will try to control the slides. Yes. So thank you for the introduction, and thank you for giving me the opportunity to speak here today. And I will talk to you about the risk of resistance associated with DoxyPEP. So why are we worried about resistance in DoxyPEP? Well, we have estimated that if we were rolling out DoxyPEP in a PrEP cohort, this would increase doxycycline consumption by a 26 to 9 times factor. In the US, they have estimated that rolling out DoxyPEP would increase the doxycycline consumption by 2.5 to 3.4 million doses every month. And in total, the total antibiotic consumption in PrEP users would increase by 17 to 55 times. And this already takes into account the reduction in doxycycline that we would not need to use to treat chlamydia infections that were averted. Because of course, if DoxyPEP reduces chlamydia and syphilis incidence, we would use less doxycycline for the treatment of chlamydia, less penicillin for syphilis, and maybe less ceftriaxone for gonorrhea. But even if we take that into account, total antibiotic consumption would increase, and this is led by a very big increase in doxycycline consumption. So this makes us a bit worried about the impact of such an increase in doxycycline consumption on resistance. So I will start speaking about resistance in bacterial STIs, and I will focus on Neisseria gonorrhea. Then I will speak a little bit about resistance in other species, and I will finish with the effect of DoxyPEP on the resistome and microbiome. So first, gonorrhea. So what the timeline shows is not very readable, so sorry about that. But it shows that gonorrhea is very good at doing one thing, and this thing is becoming resistant to antibiotics. Actually, each time that we introduce an antibiotic to treat gonorrhea, after a few years, resistance emerges, and then we need to stop using this antibiotic because it doesn't work anymore. And as you can see on the right side of this timeline, we are heading towards a situation where gonorrhea is untreatable. And this is really something we want to avoid, and we have very few options left for the treatment of gonorrhea. So what do the DoxyPEP studies say about gonorrhea? What did they find? On the left, you can see data from the DoxyPEP study, the one in the US. And you see the proportion of gonorrhea isolates that were resistant to tetracycline at baseline on the left, and then during follow-up in both arms, so standard of care and DoxyPEP. And what you see is that there was more resistance in the DoxyPEP arm compared with the standard of care arm. On the right side, you see similar data from the French study, so that's the DoxyVac study. And what you see here is that at baseline, there was 100% resistance, but it was a very small number of isolates. And it's also not completely unexpected because we know that tetracycline resistance is more frequent in Europe than in the US. But what you also see here on the right is that during follow-up, the high-level tetracycline resistance was significantly higher in the DoxyPEP arm compared with the no-PEP arm. So here we really saw an increase in high-level resistance, even if you already had resistance at the beginning. Sorry, yeah, that's the next slide. And so there was a modeling study done in the US where they tried to assess what would be the impact of rolling out DoxyPEP on the prevalence of gonorrhea over time. And they did this according to different uptake scenarios, which are represented by this colored line on this graph. And we see that in all these scenarios, we will see a decrease in the prevalence of gonorrhea in the beginning, but that this effect will actually appear and that the prevalence will start increasing again. This is because DoxyPEP will stop working at some point. And it will stop working against gonorrhea because of what we call the selection of resistance, which I will try to explain to you here. So let's say that these gray circles are gonorrhea bacteria, and the one that carries this red line also carries tetracycline resistance. So the other ones are susceptible to tetracycline. So if we give doxycycline to this population, we might eradicate the susceptible bacteria, and the one that is resistant, of course, can remain, can multiply, and can spread. So by giving doxycycline, we actually select for the strains that are resistant to tetracycline. And this is the reason why DoxyPEP will work in the beginning against gonorrhea, but after some time, we will select for these resistant strains, and then it will stop working. If you had paid a lot of attention to this slide, you might have noticed this, the fact that we no longer use tetracycline for the treatment of gonorrhea since 1986. So you might wonder, why should we care about tetracycline resistance in gonorrhea? Because we don't use it to treat it anymore. But this is because of the risk of cross-resistance, so that is the selection of resistance to other types of antibiotics. And I will try to illustrate this here. There are different ways in which this can happen. One is called the indirect pathway, and this is the one I will illustrate. So you remember this figure from a couple of slides ago, but this time the gonorrhea that carries tetracycline resistance also carries ciprofloxacin resistance. And so by giving doxycycline to this population, again, we might eradicate the susceptible bacteria. The ones that are resistant to tetracycline will remain, but they are also resistant to ciprofloxacin. So by giving doxycycline, we actually select not only for tetracycline resistance, but also for resistance to other types of antimicrobial. And this is why we are concerned about tetracycline resistance in gonorrhea. So is this really a risk? Well, in this study, they analyzed almost 6,000 gonorrhea isolates from the US. And what you see on these graphs on the right is different categories of tetracycline resistance. So we have susceptible, intermediate, resistant, and high-level resistance. And on the y-axis, MICs. I don't know if you are all familiar with MICs, but it's kind of a way to measure susceptibility or resistance to antimicrobials. And the higher it is, the more resistant the bacteria is, to put it a bit simply. And what we see is that there is a correlation between resistance to tetracycline and increased MICs in this antimicrobial. So there is a risk of cross-resistance. If you look at high-level resistance, the effect is less clear, but still we are worried because of these higher MICs in resistant isolates. And we did a similar study in Europe. We found the same result. And then again, this is data from the DoxyVac study, which is a French study about DoxyPEP. And what they found here is that there was the percentage of gonorrhea isolates with reduced sensitivity to cefixime was higher in the DoxyPEP arm compared with the no-PEP arm. And this is really worrying because cefixime is cephalosporin antibiotics, which is from the same family or the same class as ceftriaxone. And ceftriaxone is almost the last option we have for the treatment of gonorrhea. So the fact that cefixime resistance was increasing in this study is actually very worrying. So this was it for gonorrhea. So now let's have a look at the impact of doxycycline on resistance in other species. This slide was just shown by Laura. So this increase in Staphylococcus resistance in the DoxyPEP arm compared to the standard of care arm. So I will not spend too much time here. This is a very interesting systematic review which assesses the impact of oral tetracycline on resistance in the normal human flora. They included 7 RCTs in different anatomical sites, and most of these studies found an increase in resistance following tetracycline use. And so the authors conclude, although the effects are modest and transient, limited data from these studies suggest that oral tetracycline increases resistance in subgingival, gastrointestinal, and upper respiratory tract flora. And again, we don't use tetracycline to treat all these infections, but we are worried about the risk of cross-resistance. You can remember this slide from a couple of times ago. But does cross-resistance occur in other bacteria? In this study, my colleague Chris Kenyon assessed the association between minocycline resistance, so it's a tetracycline antibiotic, and 8 other types of antimicrobials. And he did this in 19 different bacterial species, which you can see here on the left. And the associations that are underlined are the ones that were not significant, meaning all the other ones were significant. Most of them were also positive, meaning a higher resistance to tetracycline was associated with higher resistance to these other antimicrobials, with then a risk of cross-resistance. And then lastly, what could be the effect of DoxyPEP on the resistome, on the microbiome? Again, this slide was shown by the previous speaker. It's data from the DoxyPEP study, which found an increase in tetracycline resistance genes in the gut of individuals taking DoxyPEP after 6 months. And there was a dose-dependent effect. So the more doxycycline used, the higher the amount of tetracycline resistance. When we speak about microbiome composition, so you speak about the composition of the normal human flora, the DoxyPEP study didn't find any effect, as Laura said, but in this study, they found that the use of tetracyclines was associated with a reduction in the abundance of bifidobacteria, which are bacteria part of the normal flora. This is a logarithmic scale, so although this seems like a small decrease, it's actually a very big decrease because of this logarithmic scale. And we know that the normal human flora is very important for health. There is more and more evidence about that. And in these 2 studies, they assessed the association between antibiotic exposure and long-term health outcomes. So on the left is with children, and we see that the antibiotic exposure was associated with an increase in all these diseases, which most of them are immune diseases, such as allergy, asthma, or psoriasis. And on the right, they assess the effect of antibiotic exposure and a new onset of inflammatory bowel disease. And for most antibiotic classes, they found an association, and also for tetracyclines, which is here on the with this red line. So in conclusion, rolling out DoxyPEP would lead to a very high doxycycline consumption. We will probably see an increase in tetracycline resistance or high-level resistance in gonorrhea. There is a risk of cross-resistance in gonorrhea, but also in other bacteria. And there is a risk of microbiome and resistant alterations with potential long-term effects on health. So I think we should be very, very careful before we are rolling out preventive antibiotics, which means giving them to a healthy population. And thank you very much for your attention.
Thank you, Dr. Van Baalen, not only for presenting us on DoxyPEP resistance, but also cross-resistance, which we usually not think about it, and its effect on microbiome. So it's really, really important. Thank you very much. The questions will be, thank you, will be asked after Dr. Fabian Kong. I'm really glad to announce that he's an associate professor and deputy head of the sexual health unit within the Melbourne School of Population and Global Health at the University of Melbourne, Australia. He is a hospital-trained pharmacist with public health expertise in clinical pharmacy, critical care toxicology, harm reduction, and international health. He has established infectious disease surveillance system, mainly for chlamydia, monitor emerging illicit drug use, and has established and assessed drug management systems for essential medicines in the developing country. He currently works to optimize treatment for STIs, particularly for multi-drug resistant gonorrhea infections in the mouth. These include studies of human pharmacokinetics to optimize current treatments and the development of the world's first oral human tissue model of gonorrhea infection colonization to screen emerging treatments to treat oral gonorrhea. His other interests include using e-health to improve access to testing and treatment for populations, finding it hard to access sexual health services, including examining the feasibility of a full automated online STI clinic in Victoria, Australia. Thank you, Fabian, and welcome.
Thank you so much. So today I'm going to talk about the public health implications and consideration of DoxyPEP, so putting all that information together. So today I'll talk about what the impact is. We pretty much know that DoxyPEP won't be effective in controlling gonorrhea. So what does that mean in terms of messaging and education? I'll briefly run over the antimicrobial resistance issues that we might see in STIs, particularly natriuretic gonorrhea that Thibault's already talked about, and also around the non-STIs such as commensals, particularly Staph aureus. I'll talk about current issues we have with antibiotic stewardship in people choosing to use DoxyPEP, and then the issues around potentially educating people about this information in an informed decision way. So Laura's already spoken about this, that you know, so DoxyPEP is quite effective. You can reduce the STIs, but I don't know if you see my pointer, it can reduce any STI by 60%. It's effective about 80% to reduce chlamydia and syphilis, but gonorrhea we would consider it to be not effective. And this is really depending on the level of background tetracycline resistance we see. But in the US study, we saw about a 55% reduction in gonorrhea, and that's with a background tetracycline resistance of about 20 to 30%. But in France, we saw a much lower reduction in gonorrhea, about 33% in the DoxyPEP trial, and this is because their tetracycline resistance was much higher at 65%. And in fact, all the isolates that were collected through that French study were all resistant to gonorrhea, were all resistant to tetracycline. So what does that mean? So you're trying to treat gonorrhea, but gonorrhea doesn't all get killed. So what it means is that there's some gonorrhea that's going to be left behind. And in fact, what DoxyPEP does is actually leave behind a lot of gonorrhea in the mouth. And why is gonorrhea infection in the mouth really important? It's associated with a much higher treatment failure in the mouth versus other infection sites. It's also a major route of transmission because you can pass it on through oral sex and saliva. And the mouth is actually where AMR develops through the transfer of resistant genes from oral commensals. So if we look at the UK gonococcal surveillance system called GRASP, they found that amongst gay and bisexual men who have sex with men and women, that gonorrhea found in the mouth was much less susceptible to first-line therapy of ceftriaxone versus gonorrhea found in other sites of the body. And this figure underneath here is really about the DoxyPEP study in the US about when you look at all the gonorrhea infections in the body, where are these sites of infection? So all the anatomical sites here, and where they are. So what I want you to do is, so of all the infections, I want you to look at this second blue section, and in the cohort of all the infections of gonorrhea in the body, this amount in the standard of care, this amount was found in the mouth. And once you give them DoxyPEP, of all the gonorrhea infections in the mouth, this much of it is in the mouth left. So you can see that with the DoxyPEP here, there's a substantial amount of DoxyPEP left in the mouth after giving them DoxyPEP. And we see results similar in the people living with HIV. They have all gonorrhea infections, this much is in the mouth, and similarly in DoxyPEP, this much is in the mouth. And so as Laura's already mentioned this, that, you know, if we look at implementation of DoxyPEP down to the gonorrhea control, you can see again, this was when DoxyPEP was implemented. Before that, there was about 2% per month reduction in gonorrhea cases, and after the implementation, there was an increase in gonorrhea cases. So now I'm going to talk about what, if you take DoxyPEP all the time, what impact might that have on AMR of other STIs? So we know currently that, you know, taking DoxyPEP is unlikely to cause any issues with syphilis AMR. Currently, there's no evidence that AMR exists with tetracyclines or doxycycline with syphilis. There's only been one clinical failure to doxycycline in the literature, but this person, the AMR was not assessed in that individual. lab studies have found that no AMR was actually induced using DoxyPEP in the lab. But recent anecdotal reports have shown that there might be potentially a delayed diagnosis of syphilis in people using DoxyPEP. And in these case studies, they found that the diagnosis was delayed for greater than 2 weeks after the onset of ulcers in these patients. So this is a concerning finding that we need to keep our eye on, that whether DoxyPEP then delays the diagnosis of syphilis. We know also over the last decade or so, chlamydia also has not likely to have any resistance issues when given doxycycline, and we currently don't see any evidence of AMR presently. But we do see a small case of treatment failures of people with chlamydia, and these are people with chlamydia that have reduced susceptibility to tetracyclines. And what we do know, though, in animals, that tetracycline resistance has been shown to be shared between chlamydia species in pigs, and this resistance occurs because these pigs have been fed fish meals that have been treated with tetracycline. And also, we already know that tetracycline is essentially can select for extra drug-resistant Shigella as well. And some previous studies, we see that a lot of the Shigella in MSM are already resistant to tetracycline. And so we've already seen this before, that the only main concern with STIs and AMR is gonorrhea. It's already shown that there's high-level resistance in DoxyPEP with more gonorrhea. And also in the DoxyVac arm, we saw that high-level resistance, 12% in the non-PEP arm, and 3 times as much in the DoxyPEP arm. We know, and we're probably going to expect that the use of DoxyPEP is going to generate AMR and gonorrhea. And so we know that AMR is a really important threat to human health. It costs lots and lots of money. It's really, really deadly, killing lots of people. And the majority of deaths from this publication was from 6 bacteria, and these are all human commensals. And I've highlighted Staph aureus because I will talk about that. I actually don't think that you need lots of studies and DoxyPEP tries to show that resistance is going to occur. There's lots of literature showing resistance. Reports show that, even 10 days of doxycycline can reduce significant amounts of good bacteria or bifidobacterium. It can reduce tetracycline resistance in gut commensal. Doses used in acne can result in tetracycline resistance in the mouth, the gut, and the respiratory tract. Its use in acne has also been shown to increase AMR in the bacteria causing acne. And in those doses, it also has been shown to significantly increase upper respiratory tract infections, female UTIs, and also sore throats. And the use of malaria has also shown that tetracycline resistance can occur in Staph aureus and E. coli soldiers. And a recent study also looked at amongst 14 people where they were asked to take doxycycline 100 milligrams twice a day. Remember, DoxyPEP is 200 milligram dose after each episode, so that's a total daily dose of 200 milligrams. They were told to give 100 milligrams twice a day for 8 weeks. And then during this process, they used this method called shotgun metagenomics, where essentially they were looking for drug-resistant genes in people's samples. And what they found was after this regimen that they saw the emergence of doxycycline-resistant Staph aureus, including Staph aureus epidermidis. Oops, sorry. And so Thibault and Dolores have talked about this, that Staph aureus that Staph aureus resistance was increased by 8% significantly from baseline to month 12. And what they also showed in the DoxyPEP trial was also the amount of resistance that was acquired in commensal natriuretic species in the mouth. So you have these naturally occurring commensal non-pathogenic natriuretic species in the mouth. And if you look at the DoxyPEP studies also, that at month 12, if you compare the DoxyPEP arm with the control arm, you saw a significant increase in the number of natriuretic commensals that were resistant to tetracycline. And what the study also looked at was also resistance that were acquired to other antibiotics. So in this small number of samples, there was about 20 people in the control arm and 20 in the DoxyPEP arm. But in both arms, penicillin resistance was also acquired amongst the DoxyPEP users. But in DoxyPEP users, you had these additional resistance being acquired to azithromycin and ciprofloxacin. And during that trial, they found no resistance to cephalosporins in that trial. So as Thibault already mentioned, so obviously gonorrhea is a major issue, and lots of studies have shown that there's a large potential that use of DoxyPEP can speed gonorrhea AMR spread, as well as cross resistance. Thibault's already talked about cross resistance that antibiotics can occur. That study of 6,000 isolates in the US found that in MSM, 63% of these gonorrhea samples from these MSM had intermediate MICs, and they quoted was a reservoir for rapid evolution of resistance. In Australia, they also looked at whether or not cross-resistance could occur, and they found that in the gonorrhea isolates that they found, that these gonorrhea isolates had reduced, that those with reduced tetracycline resistance also had reduced cephalosporin susceptibility as well. And Thibault also mentioned that obviously people say things like, you know, if you take DoxyPEP, then you might then not treat as many STIs, so you kind of spare or save antibiotics such as ceftriaxone. But modern studies by Harvard have shown that DoxyPEP doesn't actually prolong the life of ceftriaxone. And as Thibaut mentioned, any reduction of ceftriaxone or azithromycin used to treat STIs is actually just a high cost of high doxycycline use. Essentially, you're swapping one antibiotic use for another. So poor antibiotic coverage stewardship. So we know about 10% of HIV PrEP users in London, Melbourne, Amsterdam currently use DoxyPEP. And currently in the US, about 1 in 5 people in the US HIV PrEP users use Doxy. We know small numbers of these people are using other antibiotics such as amoxicillin, azithromycin, and ciprofloxacin using for PEP. Many people are using leftover antibiotics to prevent STI prevention, and a substantial amount of people are now buying these online without a prescription. And here's an image here of I've been following DoxyPEP since about 2018, and people have been buying DoxyPEP online without prescriptions, and that's still the case from current surveys, and it's very concerning. Just make sure that. So in summary, we certainly see there's a loud noise of AMR that will occur in the use of DoxyPEP, not only to Doxy, but also cross-resistance to other classes of antibiotics. And so what we might be able to do is target the use of DoxyPEP in people so that not everybody uses. So in Australia, our current policy and recommendations for DoxyPEP is that we should try to focus on giving these to individuals who've had a history of syphilis and not necessarily those who've had chlamydia or gonorrhea in the past. And one of the reasons for this is that we know that infections at the oral or rectal site with gonorrhea or chlamydia in MSM are generally asymptomatic, and they cause very little harm in gay men. And also these infections also tend to clear without treatment in 2 to 3 months. So if these oral and rectal infections with chlamydia and gonorrhea don't cause any harm, or don't cause any symptoms in gay men, and they're naturally clear, then we need to think about why would we use DoxyPEP to prevent these infections, and then to balance that with AMR. Of course, AMR surveillance needs to be in place to kind of look at this, especially around commensal or Staph aureus, because the commensal AMRs is what's going to kill people and not necessarily gonorrhea. But I suppose it's about the feasibility of being able to implement new surveillance systems as a result of DoxyPEP implementation. In Australia, we're not at all prepared for this. We talk about having more surveillance, but lots of money and resources need to be put into surveillance for it to work. And also, there needs to be a substantial amount of education with users about AMR and the effectiveness. So people need to be told actually that DoxyPEP is probably unlikely to be effective against gonorrhea. So therefore, if you take it for during sex, you're unlikely to be able to keep gonorrhea and therefore need to continue to be screened. AMR is an important consideration. And a recent Australian study of about over 2,000 MSN found that MSN who were concerned about AMR were 50% less likely to use DoxyPEP. And this has significant implications for education and also people selling DoxyPEP online, because telling people about AMR should be done thoroughly so that people can make an informed decision around whether they use it or not. And you actually find that a lot of websites selling DoxyPEP now won't be very thorough in terms of the evidence on AMR. And lastly, obviously use doxycycline, don't use any other antibiotics, and also to use it properly. Thank you very much.
Okay, thank you very much, Fabian, for this wonderful presentation that you summarized the health implications of doxycycline use. I think all 3 lectures were very nicely presented, the pros and cons of this prophylactic treatment. And now the floor is for the participants to ask questions. We already received some questions at the question button, and as a warming up, if you don't mind, we will start the questions in order. And the first question that we received is a little bit far from this STI topic, but of course everything is interrelated with everything. So what do you think, what our lecturers think about the use of doxycycline in acne? Because of course, acne is also an important indication for doxycycline treatment. Are there any similar resistance issues and patterns for the bacteria involved in acne if we use doxycycline for this condition? You can skip this question if you don't feel comfortable to answer now, because it's a little bit far from the topic, but of course, acne is also a very prevalent disease. So if you don't mind to answer this, then please.
I presented that data on the use of doxycycline in acne. So you'll hear lots of people saying we already use doxycycline acne, we all use it for malaria, and therefore why should we care about using it for STIs? But the studies of acne have found that the propion bacteria that causes acne becomes resistant with doxycycline. And with acne treatment, you're not supposed to use doxycycline forever. You're only supposed to use it for a limited amount of time. So there is that other proviso, but definitely resistance to the bacteria causing acne does occur, and microbiome changes do occur because you're taking moderately long-term stuff. So it will, AMR is occurring.
Yeah, so the same as for
if I can add something, sorry, go ahead.
So please comment.
No, for me, there's also a big difference between prevention and treatment. Because when we speak about acne, treatment of a disease, so these people are sick and this disease can leave scars, it can have very psychological consequences, and we are treating that with doxycycline. And I agree, it's not the first choice, it's not the best choice, there are many other options, but that's a big difference between prevention, because by prevention, we are giving these antibiotics to healthy individuals. So individuals who are not sick, who don't have any disease, we give it as a prevention. So the scale is also probably much bigger. And when we speak about prevention, we have to look at both the benefits and the risks. And if we compare with malaria prevention, because in malaria it's also prevention, but there we are preventing falciparum malaria, which is a deadly, very serious disease, which is not really the same as preventing chlamydia infections, mostly asymptomatic, and syphilis infections. It's also quite different. But I think these are big difference between DoxyPEP and treatment for acne and prevention for malaria.
Yeah, you are right. We should distinguish these two indications, of course, if we consider the risk and benefits. Okay, other comments to this question? Then I give the floor to Darija to introduce the next one.
So I found one question in an answered question going to Dr. Laura Bachmann about from Emmanuel. So she writes that in Nigeria, there is an ongoing myth and still exists amongst the majority of the population, although not evidence based on the use of ampicillin, cloxacillin, at the dose of 500 milligram of PEP for STIs. Is there a correlation with this and DoxyPEP? Are you aware of any study or research backing the use of ampiclox as PEP? Thank you.
I think Fabian may have indicated he wanted to answer this one live, but I will say that that antibiotic has not been studied for this indication, to my knowledge, and should not be used. And we do know, I think Fabian also pointed out in his talk that people have used other antimicrobials besides doxycycline for this purpose. But again, it would be important that, we know that there are concerns even with this one antibiotic where we have 3 randomized studies that show that there's some benefit in this population. There's already concerns there, and certainly using an antibiotic that has not been studied would not be recommended. And I do also want to point out, I think some of the, the points that have been made by the other 2 speakers are very well taken and really important. I think this is a very complicated situation in terms of how the impacts will be further beyond the individual with decreased STIs and how onward transmission will be impacted. And antimicrobial use from onward transmission, et cetera. I think those are going to be important things for us to follow to see if there is any benefit there. And also, there's also the asymptomatic bacterial STIs. I think that is an important point to make. At least in the United States, though, there's overlap in the population. So while this is an intervention right now that's recommended for men who have sex work men and transgender women with that history of STIs, with the point of trying to reduce the use of the antibiotic, except in people who are more likely have, to need treatment later for a STI. I think we don't know, again, how much this overlap is going to play out into other populations. And those are all things that need to be evaluated along with, as my colleagues have pointed out, these resistance data and how they're going to play out in real world implementation settings.
Thank you very much. So we have a lot to discover. I have a question for Fabian Kong, Professor Fabian Kong, and then the rest of you can, Dr. Bachmann and Van Balen can answer. It's a pharmacist-related question. Given the concerns of AMR, what role can pharmacists play in monitoring adherence to DoxyPEP and ensuring its judicious use? Besides, in addition to, as you said, education of patients, as you really pointed out this in your summary?
Look, I think pharmacists, so at the moment, a lot of people are buying doxycycline online, and a lot of those people are going to be pharmacists, unfortunately. So there is websites now in US and India where generic drug companies are selling doxycycline. And I think that if you're going to sell it online, tell people about, at least inform the people about AMR, be really truthful about its effectiveness, not against gonorrhea. So at least if you're going to try to do it illegally, try to inform them about it. So I think pharmacists have a really, really good role in trying to prevent that to happen. And then also providing all the necessary information around how to take it properly. So I think pharmacists have a critical role in doing that. And all the hospital pharmacists have a critical role in antibiotic stewardship. So if I hear about people using unstudied antibiotics to treat these things, provide some education to the users to not do it and things like that. So pharmacists will come up. So I think hospital pharmacists particularly will probably see lots of these things. Community pharmacists are difficult because they may have a commercial interest in selling antibiotics and that may overrun the other public health concerns. But pharmacists at the forefront of selling antibiotics should be really mindful of what this DoxyPEP is going to do for AMR.
Okay, thank you. I checked the question box and I see a question which is what can, because we have heard about the negative effects of doxycycline use as a prophylactic agent. So, and we know that it's not good for every sexually transmitted infection. So the question arises that do we have a better preventive measure which maybe have a effect on more sexually transmitted infections, or what are the other solutions that we should consider? Any of you can.
I can start with that. I think the point is that, again, this is not an intervention that should be in isolation, given in isolation. So, and it's, for that reason, I think that I agree. I think that its use for gonorrhea is, we're seeing in the early implementation data that it's not holding up, which is not entirely surprising. So, there are other ways to prevent STIs. We don't have another antibiotic that would be recommended to hit, at this point to prevent all STIs, but there are other measures that can be taken to prevent STIs. And so these other risk reduction measures should be discussed with the patient as well. The things we know about condom use, reducing numbers of partners, being vaccinated for what you can be vaccinated for, because, Mpox, for instance, we're seeing that in certain populations, and there's, not an antibiotic to address that. So, I think the point is that this is a comprehensive plan with a lot of discussion about what the points that have been made about AMR, microbiome, unknowns, but potential benefits as well. And I think that's going to be really important. And I think also this assessment, again, this is not envisioned to be an intervention that is used indefinitely for the lifetime of the person. There's, people have different situations over their lives. There are different places, and that's why it's important to have this ongoing conversation about, what's going on with the individual and whether this is, if they had elected earlier for it, do they, you know, is it still, do they still need it? Are they still having benefit from it? So, I mean, that's what I would say about that. I don't know, my colleagues may have additional points that they would like to make.
Okay.
Yeah, there was sorry.
Yeah, other comments, please.
Yeah, there was some hope for a vaccine because we thought that the meningitis B vaccine would also work against gonorrhea, but the last study didn't really show convincing results. So it's not very clear if there is an effect, and if there's an effect, it's not very high, or quite short. But of course, the vaccine would be the best option for gonorrhea, also other STIs. There are some in the pipeline, but nothing is yet implemented or available.
Yeah, I think, Tipo, you're right. So I think the gonococcal vaccine that you were talking about, it's interesting because the results show that the reduction in gonorrhea had a statistical value of 0.06, right? So, you know, in statistical world, anything more than 0.5 is considered not statistical. But, you know, that's a pretty close statistical value. And I think that given over time, we may see some small effect of the 4CM, the meningococcal vaccine against gonorrhea. And just to let people know that in the UK already, despite these results, they have already started to recommend that gay and bisexual men or people at risk should be given this meningococcal vaccine to prevent gonorrhea infection. So they've rolled out that implementation. They've recommended it, but they haven't rolled it out yet. So there is countries that are already starting to do vaccinations against gonorrhea using this vaccine. My other comment also is there's also been discussions around the world about whether or not we should reduce the frequency of testing in men who only have sex with men for chlamydia and gonorrhea only, because these infections in gay men who don't have any contact with anyone with a uterus don't cause any harm or cause any symptoms, right? So one of the main reasons to do that is we want to reduce the amount of antibiotics that MSM use to reduce that AMR, right? So the question that we need to start thinking about is that if these infections don't cause any symptoms, don't cause any harm, they're naturally clear, why would you want to try to prevent these infections? And it's a very controversial comment because people want to take it to not pass it on to their partners, whether they be casual partners or their regular partners. And there is this psychological stress that they don't want to pass something on. But we need to start thinking about the harms of taking drugs for AMR when it actually doesn't cause when those STIs don't cause any harm. So that's just something to consider. There's lots of literature now about asymptomatic testing and reduction in frequency. And lastly, I wanted to say, particularly those coming from low middle income countries, with your poorer surveillance systems around AMR, particularly around menstruals and stuff like that, you're likely to also see much more higher levels of AMR in your countries because of your unregulated use of antibiotics. So you particularly need to be more vigilant around what DoxyPEP and antibiotic use might be doing in your countries, and you might need to be more vigilant in your particular countries. So, and that's my overall comments.
Thank you. It's really important to know this as well. I would like to ask Dr. van Baalen, is the increased number of bacteria STIs a consequence of people stopping to use condoms because of HIV PrEP, or is because more cases are detected due to the regular screening for the infections that people of HIV PrEP undergo? Could alternative preventive measures for bacteria STI be used or conjunction, or we already covered that, but about the screening, it's really interesting to repeat this.
So, so can you repeat the beginning of the questions, because there were several questions in one question and I forgot the.
So, is the increased number of bacteria STIs a consequence of people stopping the use of condoms because of the availability of this therapy, or it's because more cases are detected because of more screening, regular screening for infections that these people go?
Yeah, it's both. So we know that we test more, and we're testing more now than we've ever tested. And so, of course, by testing more, especially asymptomatic infections, you will find more infections. And so the incidence will increase because you find more. But we also know that there is less and less condom use, and so for years. Probably as a consequence of better HIV treatment, other prevention methods, and people who are tired of condoms, less awareness about STIs and prevention methods. So it's probably a combination of both. We know there's increased circulation and transmission, but we also know that there is more testing, and both are responsible for increases. And then what was the following question?
The question about so could alternative preventive measures for bacterial STIs be used in conjunction with or instead of DoxyPEP? But I said Fabian already talked about the education. But you can also and vaccination. You can also add.
But indeed, the vaccine, the significance was borderline, but the effect was also around 20%. So even if it was significant, it's not a very big effect. We would have to see in real life what it does and for how long the protection lasts, because it's also something we don't really know. And we hope of new vaccine. But as Fabian said, there is a lot of discussion nowadays around the asymptomatic chlamydia gonorrhea infections in the MSM and the relevance of it, whether we should be screening for it, whether we should give DoxyPEP to prevent these infections that clear by themselves and that have very few or almost no complications in MSM. And I completely agree with that. And Fabian knows, I think, our point of view on that topic in Belgium. So that's a very interesting debate that will continue in the coming years, I think.
Thank you. Do we have questions or sorry, do we have time for more questions or should we wrap up? Timothy?
I just want to talk about the gonorrhea vaccine. The first time we kind of knew that gonorrhea vaccines could reduce gonorrhea by 30% was done in New Zealand. They did a large scale vaccination program, then they followed these people and found a 30% reduction, right? So they've recently published a paper around the effectiveness of how long they think that vaccination course would have had lasted. And I think it's 3 years. They think that you need to revaccinate for 3 years. But I also like to think about the different doses that we use in the vaccination courses for these people using the meningococcal vaccine, right? I think the New Zealand people vax people 3 times, I think, and at different schedules, whereas the current trials are dosing people twice and 1 month apart. So I'm just not sure yet whether or not the dosing regimens that we're using for doxycycline prevention for gonorrhea prevention may be the correct optimal dosing. And I also want to lastly say that we've always been talking about everyone needs to screen and treat, and lots of screening can therefore reduce transmission and reduce prevalence. But to date, that hasn't occurred. STIs continue to rise despite the increase in numbers of STI screening that we're doing. So just to let the audience know that the testing and screening policy has failed and it's not doing what we want it to do. So that's why there's a reevaluation of what we do down to the screening, who we screen, how often we screen. And that's something that's in our field of research at the moment. So they're my final comments.
Okay, thank you. As a wrap up, my understanding that we have seen from the lectures that doxycycline used for the prevention of STI is an effective measure. But as we heard about the long-term consequences relating AMR or relating other health outcomes, I think we should just follow the guidelines and we should make a decision on every individual case, and we should not think that this is a lifelong thing, but this should be adjusted to the life situation of the involved people who might be eligible for this preventive measure. And we should not forget, so this is not a thing that will solve STI to use doxycycline, but we should pay attention for the other preventive measures, what we heard about the physical barrier, the condom, and vaccines, and of course the continuous screening for the early diagnosis. And so thank you for all. I don't know if Darija would like to add something.
I would just like to that all of you panelists say your final words, starting from the start, Dr. Bachmann, then Dr. van Balen, and Professor Kong. Just one final thought for our audience, please.
I mean, I can start, and I just want to, we didn't get into this that much, except I think Fabian and Dr. Kong mentioned it, but, you know, you are very important providers. The reach of pharmacists is way beyond, I think, what, other healthcare providers have. And so I just want to emphasize the importance of, and I'm glad that we're having this discussion today. And so that when you are encountering people asking about this intervention, that you can give a balanced view about it. But want to emphasize that to keep up the good work you're doing, and the importance that you have to the health of people in general. So thank you for having me today to speak with you.
Dr. Van Balen.
Thank you, and I can only agree with Laura that pharmacists play a very important role. They're often the very point of contact of patients with the healthcare system and a very important source of information. And so I think that giving correct information on both the benefits and the risks of DoxyPEP, so yeah, the reduction in incidence, but the concerns of AMR is really critical in this topic. Thank you.
Yeah, and I agree. And I think pharmacists, particularly, you have this training in antimicrobial stewardship. It's just part of the training that you do. Apply it to everything that you do in terms of dispensing medications, and particularly around this DoxyPEP area. So you do this every day. This is just another extension of those skills that you do. So keep it going.
Thank you very much for these encouraging words. So I believe that all of our listeners will definitely start to implement them and be motivated to implement in their community, hospital, or industrial life, or to produce a new vaccine that will be really effective. Thank you very much, and thank you, FIP, for hosting this event. Thank you.
Thank you, everyone.
Thank you. Thank you very much.
Thank you.